Hello. So, first of all, a DME consultant is, I work for one of the accrediting bodies, and I can help DME companies get ready for their re-ups on their accreditation, get new accreditation, things like that. That's what it is, yeah. So, today I'm going to talk about the safety topic that we need, some transitioning and managing patients using technology. And I really do feel like we've got a preview of my talk when we were doing our panel up here. So we'll go ahead and jump into a few things here. So the objectives. Describe how to predict the future from a patient's past clinical data. Discuss strategies for tracking symptom data, and outline the ways to identify the appropriate preventative care interventions using your data. So, my formatting didn't come over right. This slide looked cuter. But, so when they just asked me if I wanted to do the safety talk, I just couldn't get it out of my head. I'm like, safety, safety, safety. And every time I just kept thinking about safety signs and like OSHA safety. So I decided to just have a little corny theme, and so through the whole thing we're going to be having little signs come up, and we're going to change them to be relevant to our topics. So, alright, so our first little sign is caution. What's your step? But let's talk about caution, track the symptoms. So, we were talking about that earlier. This is what we do in our call center, is we track the symptoms, and then we notify the DME companies when we start to notice a decline, or we see a potential intervention that we could provide a patient that might cause them to not have to go into the hospital or have an exacerbation. So then I started thinking, like, how do our patients even know? Are they having an exacerbation, or is this just a bad day? I mean, everybody has bad days. And so I was looking it up, and the first steps is really knowing if this may be an exacerbation is watching for the changes in their usual symptoms, because all of our patients have symptoms. I'm mostly talking about our COPD population right now, and so everybody's symptoms are different. So everybody is going to be needs to key in on what their symptoms are and what their normals are. So we're going to talk a lot about that today. And so the quicker that we realize they're having a problem, the quicker we can take action to prevent it. And that's what we try to focus on in our call center. And I know that the DME companies that do use our program, they have all started doing the same as well. So warning signs can be different for every patient. So I Googled common symptoms of COPD. And I did it because I was lazy and I wanted to copy and paste on my slides, okay? But then I was like, how many patients have done that? And then I thought, okay, let's see what common symptoms of an exacerbation is. And look at there. They are identical. I was like, wow, there's not one single difference. And Google knows everything. So what are our patients supposed to do? So I was really shocked when I was like, okay. And then I started thinking about it. I'm like, they couldn't even have put a more or worse, before any of that. So I was just thinking, this is really, sometimes our patients, this is the only education they get. And, when the internet first came out, everybody was doctors. Everybody knew their diagnosis, and then it's the same thing. Everybody's looking at it. Everybody's checking it. So I just thought this was really interesting. So, it's the truth, too. The symptoms are the same for both. But what's the difference? Worse. They're getting worse. So it's not easy for patients to even know the difference of a bad day or a real true exacerbation. So how many times have you went to patients' homes, and how many times have we heard these on our calls? Because I listen to a lot of our calls. I do QA on our calls, and I hear this all the time. I just feel bad most days, and they do. So how are they supposed to know when they're really, truly starting to have an exacerbation or maybe developing pneumonia or whatever? Because they feel bad all the time. I cough like this every day. I remember my grandparents used to get up in the morning and you knew they was moving because they was a hacking. I mean, that's just the way it is. I always have to use more, my inhaler more than I'm supposed to. I'm sure everybody's heard that a lot too. You know, and these are just a few comments that I've took from just my experience and some of our calls. I have a horrible headache in the morning. That's, you know, big one that people say a lot. So we're going to talk about how to educate your patients to know how to track how they feel each day. And I want to go to the next slide because I made it a little bit bigger on here. So there's different tools that you can use to teach your patients how to track their symptoms. You're going to have patients who look at, I'm just going to flip it real quick, something like that and get so intimidated. They're like, I don't even know how to read all of that, you know. So think about those patients. They all probably got a calendar at the bank. It's got a kitty cat on it, you know. Bad day. Track it, you know. Say, today I coughed up and it was green. You know, just do something simple. Just make them realize that today is different than yesterday was for whatever reason. Maybe you did wake up with a headache today. And when they go to their doctor, they can at least say, I've been tracking it and I wake up with a morning headache 5 out of 7 days. You know, or I've had to turn my oxygen up past what you've got prescribed 5 days this week. And what did you do on those 5 days? You know, so even if it's as simple as the calendar, you know, just have them document something. There are symptom journals out there. If you type it in on Amazon, you'll get symptom journals popping up on Amazon so they can document it. And it'll say things like, did you cough today? What color was your sputum today? Like, it'll guide them through it. You can also do that. And then the CAT assessment. I'm going to go into the CAT assessment just a little bit more. I've got a slide on it, so we'll skip it, and we'll skip the action plan because I've got a slide on it as well, and we'll go into more detail. But have you ever gone to one of your app stores, Google Play or the Apple Store, and typed in COPD? Boom, baby, there's so many apps out there. You can track your symptoms on any app you want. There's tons of information. Like, it's crazy when I did that right after I Googled. So, like, it is crazy how much is out there. If a patient feels comfortable doing it, have them download it. The one from the COPD Foundation is COPD Pocket Consulting Guide, and they actually do have on there the CAT assessment, where they can actually click it on the app and it'll track it. But just seriously, just for your own benefit, go into your Google Play or your app store and just type in COPD and you'll see all the different apps that pop up. And then, of course, Nexus, brought to you by us. So we'll go into more Nexus here in just a little bit as well. Okay, so the action plan. Has anybody ever seen this? Has anybody ever done this with a patient? Show of hands. Good, okay, all right, awesome. I wanted to make sure my customers raised their hands because we definitely use this. So this looks complicated because there's a lot on this, but it's extremely simple. I've never worked with a laser before. Here we go. There we go, okay. So basically you're just gonna have them document their information up here, but then here, you're gonna actually talk to them and say, on my best days, and it gives you all the instructions right here. And there's an amazing video on the COPD Foundation's website that will go through how to fill it all out as well. But, so you just go here and you say, okay, we're talking about on your good day, your absolute best day where you feel great. What can you do? That's what you need to focus on for this box. And make them realize, even on my best day, I can't clean. You know, make them understand that, oh, you know what, I'm able to clean on my good days. And then when a day comes where they can't clean, they'll think, oh, this is actually a bad day. And the one thing that you want to make them understand is it's okay to have a bad day. We all have bad days. I'm having a bad day today. I did not want to get out of bed today. But I probably won't have it tomorrow. That's the key, is they need to understand bad days happen, but they don't continue to happen. And what they do is, and I mean, every patient I've seen, especially when I've gone out and done the Nexus assessments with patients in the home, they get so used to bad days, they don't keep up anymore. It's just another bad day that turns into a hospital stay. So you simply go through each category with them, and you give them these options, and you answer every single category. And that way they can understand what they do on a good day. And on this one, it's my favorite. So I think it was Dr. Landon that mentioned earlier, just walking to the mailbox, or maybe it was Tim that mentioned it. Just walking to the mailbox, that's a win for some people. And one of the questions in our program we do ask is, this is called our motivational goal. What do you want to be able to do? And you know, I tell people, be realistic, because I've had patients say, I want to run a marathon. And I'm like, okay, did you do it before you got sick? Like, you can't. And they're like, no. And I'm like, okay, how about we start smaller? Like, you want to go to the grocery store. So, you know, you want them, though, to, something they miss, some reason why they want to take better care of themselves so they can truly get to where they need to be. So a lot of the times we do have, I want to walk to my mailbox, because I know my mom and daddy they peek out that window all day till the mail comes. And that's what they want to do, hightail it out, you know. And that's a big deal to a lot of people. And so that's the answer we get a lot. We've had answers like, I want to go to my niece's wedding. I want to go to my family reunion. Go back to working part-time. You know, there's a lot of different answers. Play with my grandkids. Be able to babysit my grandkids again. You know, we've had all those answers. So that's why that one is so important, because that's their motivation. Their buy-in to making themselves feel better. And it gives them a sense of empowerment, because one of the things that we've always talked about is don't treat the patient. Let the patient want to be treated. If you just come at me and tell me, you have to do this, you have to do this, you have to do this, I'm not gonna want to do that. But if you come at me and say, if we do it this way, here will be the outcome, and it could be better, I'll be like, okay, I'll make my own mind up and I'll decide. You know, and I feel like that sometimes patients feel like, and there's a lot of articles out there that support the fact that patients feel like they are bulldozed into their own treatment. You know, my mother's dealing with cancer right now, and she switched doctors because the doctor was like, you're doing this, and she was like, oh no, I'm not. Like, you don't get to choose for me. And she was very offended that he told her she was doing this. So that's what we do with patients every day. So that motivational goal really helps them say, you know what, here's why I'm doing this, and I want to work with you to do this. So then down here, you'll have them check off what is their normal days. And then here, these are their take action days. And so, their take action for their good days. And make sure they update this plan every 6 months, because things change, especially with our COPD patients. You want them to take this to their physician, because obviously we don't tell them what to do when medications and when symptoms start, but have a plan. If you start having a yellow day, what are you going to do? Talk to your physician. We're automatically going to switch you over to inhalers more often, or you know, you're going to call me and I'm going to get you some antibiotics if you need it, or some steroids, whatever. And then, of course, your red days. What action are you going to take on those? So it's really awesome to see a patient feel empowered by being able to talk to their physician and be a part of their care plan. Okay. The CAT assessment. It's my favorite. I feel like the CAT assessment does not get the, oh Lord, I lost words. It doesn't get the respect it deserves, because it is so simple. And because it's so simple, people kind of poo-poo on it, you know. It's like, oh, 1 to 5, okay, you know. But if you have done CAT assessments on patients, has anybody in here ever done CAT assessments a lot on patients? Oh, yeah, I love this. Okay, good, good. Especially my people over here, yeah. It's all right. Ooh, ooh. So when you do this, you really see the tracking of the good and bad days. It is amazing. It's so interesting to look at our patients' history on these CAT assessments. And the key with the CAT assessment is don't answer for them. You've had these conversations, you know them. And so you're like, oh yeah, you cough a lot, I'm going to give you a 5. No, that's not the way it needs to be done. It needs to be the patient telling you what they are. And sometimes they don't want to tell you when you're asking them, okay, between I never cough, I cough all the time, give me a 0 to 5. Give me a number. Oh, yeah, it's all, I do, I cough a lot, yeah. Okay, give me a number. I need that number from you, because the next time you're going to have them give them that number. And if you pick that number, you're not comparing what they say the next time if somebody else guesses the number for them. Okay. I like all my girls back here shaking their heads. I know y'all do it too. So the tracking on this, though, is extremely interesting. If the CAT scores, a normal CAT score is a score of 10. That's your perfect normal patient. I mean, none of our patients are that. I mean, when we're looking at ours, we're more like 22 and up in the 30s. And we say we've got 100% success on our badges in our program if we drop their number by 10 from the baseline. I mean, that's a lot of progress, because if this number moves 2 points, they may be about to have an exacerbation. It's a really powerful tool. And once you see, I'm just going to show you an example. This is our tracking of our CAT assessment in our Nexus program. Now this one's a little dramatic, but I wanted it for effect. But you could really see where patients, can have, they're 30, and like I said, remember, it's a 10. They're up here to 30 because they feel really bad. You come down here, they had their antibiotics, steroids, they're riding that steroid, boy, they feel good. Steroids wearing off, okay. In a month, I'm back up here. I mean, this is the kind of trends that we really do see with our patients. This one is a little more dramatic, but you see what I'm doing here. These are the trends that you can get from your patient. You can really have a lot of insight with them. In our call center, we do use the CAT assessment a lot to make referrals and to call DMEs and say, this patient's had a significant decline. You may need to send a respiratory therapist out, or maybe, you need to have either your therapist or your sales rep reach out to the physician. And in a little bit, I'm going to actually show you guys a progress note of some of the information we send to people. Okay, here we go. Harmful chemicals. Now it changes to harmful triggers. Nobody liked this. No, everybody I showed, they were like, I was like, I think it's cheesy and I love it. I'm doing with it. So let's talk about their triggers. We already talked about symptoms and how exacerbations were completely different for everybody, and nobody's the same. And it's the same with triggers. So, of course, when you do your common triggers, your respiratory infections, smoking, and even secondhand smoking, the weather, humidity, cold, hot, it could affect them negatively. Environment, dust, fumes, cleaning products. A lot of people have wood-burning stoves in their homes. And then, you have your uncommon triggers. Anxiety, family. Yeah, right. You might need to stay away from a few people to keep you out of the hospital. So medication changes or medication errors. Like, for example, you think, okay, the newest and greatest, and they've had an awesome sales rep, and now they're ordering a certain brand of inhaler for all their patients now. That's not going to work for all their patients, though. And so if they have a new medication, they'll think, oh, my doctor ordered it. I have to take it. I have to take it. But if it's not working, you don't have to take it. You need to go back to your doctor and say, I feel worse on this. And I think a lot of patients don't know that they can be empowered to do that. And that's where we need to come in and say, we're tracking your medicine changes. You just told us you had a new inhaler, and now the inhaler that you're on, you're starting to decline. How do you feel it's working for you? Well, you need to talk to your physician about it. I'm going to call your physician and tell your physician about it. You need to empower them to know that it is okay to say, I don't think this is working for me. Of course, lack of understanding. How many times have we gone into homes and people are using their steroids thinking it's their albuterol, Or when I just take that steroid when I start feeling bad, like, no, that's not how that works. So lack of understanding, of course, is always an issue. And new medications we talked about, and ability to take the medication correctly. I don't even have a slide in here about the in-check, but the in-check dial is one of the best kept secrets of respiratory therapy. Does anybody in here use an in-check dial with their patients? Yeah, right, yep, I love it. So, do what? Yep. And a lot of times you have to change, don't you? You have to get them switched over to a nebulizer. Right, exactly. So, medications that they've changed to, they may not even be able to do them. And not even that they're not working, they can't even get the medication in to see if it's going to work. And then, of course, diet is another big issue for COPD patients. All right. Beware of alligators. Danger, beware I have learned so much about bronchiectasis in the last year. I love talking about it now, and I love trying to get patients on vests for it, or high frequency chest walls, my bad. So what is bronchiectasis? So bronchiectasis is a long-term condition caused by underlying lung disease where the airways of the lungs become widened, lead to buildup of excess mucus that can make the lungs more vulnerable to infection. Makes sense, right? You would think COPD patients when you read something like that too, wouldn't you? I mean, that kind of goes hand in hand. So who does bronchiectasis affect most? People living with underlying lung conditions. Now, when I read this, and I've done, my research on this, like I said, for the last year, I've been very interested in this. The underlying lung conditions that affect your lungs or your immune system. So, of course, cystic fibrosis. That's number one for bronchiectasis. And then, asthma, fungal infections, immunodeficiency disorders. But COPD is not on that list. And that was very surprising to me because it is extremely underdiagnosed. And I thought, why is COPD not even on that list? That was just very interesting to me because I think your lungs are affected in a negative way, COPD. Like that just immediately to me should match. But that is not one of the underlying lung diseases. So here we go. What I did was Googled it. And look here. Most common symptom of bronchiectasis, I put it in just like I did on the first two. The most common symptom is a persistent cough that brings up a large amount of phlegm on a daily basis. You remember my mama and papa hacking that morning? Every day. That's what they did, every day. Shortness of breath, wheezing, coughing, blood or blood-stained sputum, chest pain, joint pain. Now, joint pain is different, but every one of the other ones are all on the COPD list. So the research suggests that 52% of COPD patients also report bronchiectasis-related symptoms. I mean, 52% seems low to me almost, just from the patients that we deal with on a daily basis. So, I don't think that people are really looking at it like that. And that's one of the things that we really try to focus on in our call center is, do they possibly have bronchiectasis? We do have the question in there. Have you ever had a CT scan? Have you ever been told you have it? So we need to get these people on the right type of intervention for them. So to diagnose it, you can do it by a chest CT scan or an x-ray. They do blood tests and sputum cultures and a bronchoscope. So when you go into the hospital, and they talked about this earlier, trachs bring a lot of money. So does COPD. But bronchiectasis isn't as high paying as COPD diagnosis, chronic respiratory failure diagnosis, acute respiratory failure. So you also have to do a lot of testing for this. So when you are getting billed for COPD diagnosis in the hospital, they can base it on symptoms. But from what I've seen is if they're going to try to say you have bronchiectasis, they have to have the underlying lung disease diagnosed, and then they also have to have a test done on you to say that you have the bronchiectasis. So I think that's probably, again, part of why, because there's a cost factor to patients and not as beneficial to other people that for bronchiectasis. So safety first. How about home interventions first? So this is where we're going to talk about using the past for better outcomes. Review your symptoms, your symptom tracking with each visit. Try to identify trends that maybe they've not even identified or reported to you. Of course, I listed just out a few, and morning headaches that they're having very often, a productive daily cough, unscheduled doctor's visits that are resulting in them getting antibiotics. That is one of the biggest symptoms and signs of bronchiectasis, is that they have frequent hospital visits that result in antibiotics being given to them. Unscheduled hospital visits, and when they were in the hospital, were they on a non-invasive? Did they get intubated? Those are questions we need to ask anytime we know a patient's been in the hospital and they're on our home program. What happened while you were in there? What kind of treatment did you get? Review the patient's history and supporting documents. We want to know what diagnoses do they have. See if they have a diagnosis of bronchiectasis. Testing. Did they get a CT scan, x-rays, PFTs, ABGs? All of these things are supporting documents that we use to provide our DME companies with a path for an intervention. So if we identify that somebody's declining, we'll actually go into their billing system and look at all the documents they have on that patient and see if they have any of this information. And then we will actually send, and this is this is actually a real patient that we have identified that needs an intervention for one of our customers. So it's a patient, COPD, asthma, obstructive sleep apnea, and then they have a few more diagnoses. They're currently on oxygen, 3 to 4 liters, 24 hours with a BiPAP at night. They're on Brio and albuterol. Their chief complaint is chest tightness, shortness of breath, and fatigue. You remember those slides, those Google slides? Those are all listed on there, both of them. So then we were able to find an ABG on this patient. And so we were able to see their CAT score is 32. And you remember I told you 10 is a normal CAT score. So that's significantly higher. And they've had 3 hospitalizations in the past year. So we don't always get the documents from all of those. If they didn't order anything new from the DME company, they don't always have that, but the patient does self-report that to us. So we spoke with Ms. Doe for a follow-up telorespiratory assessment, so we've called this patient before. She's struggling with her breathing and now has increased her oxygen liter flow, 3 to 4 liters, and has increased usage for her albuterol. Her CAT score has increased from 30 in June to now 32, and I'm not sure what month this was. We just pulled one for me. She stated that she's had 2 ED visits, 1 hospitalization, and had to be treated with antibiotics and steroids for respiratory infection. So that's a huge sign that could be bronchiectasis. All of those, the daily productive cough, all of that. She complains of morning headaches and neck pain. She's very short of breath with any exertion and is very limited in her ADLs. She continues to not sleep well, has no energy through the day despite being compliant with her BiPAP on 4 liters. She states, I do not have any energy. And I will say, when you're talking to a physician, we have learned this over the last year and a half, they don't have time to read a lot of this stuff. We actually did an exercise where my navigators came to me, like I was the doctor, and I had them try to sell me on their intervention, their suggestion for this patient. And man, they talked, and they talked, and they were great. Super intelligent people work for me. Like, they're awesome, and I'm like, I got 75 more patients to see today. I don't have time to deal with this. Like, give me a piece of paper, let me look at it quick, to the point. And it also needs to be urgent. Like, they need to see that the patient is having this problem. And so when you think about when you're talking to a physician, you need to get to the point, be direct, and show the urgency that the patient has. So we are huge on quotes. So I do not have any energy. Any quote that our patient gives us, we put in the notes because they need to know what their patients are saying to us. And so on this one, we we did consider NIV to improve symptoms and slow down the disease progression, and also consider NEBS. So I'm going to say that at some point through there they mentioned they were probably having trouble with their MDI. Go to the next one here. Okay, so this one, asthma, obstructive sleep apnea, post-COVID pneumonia, restrictive disease, 2 to 4 liters, 24 hours, 2 liters with CPAP nightly. So they're on Symbicort, albuterol, NEB, and look here, they have a flutter valve. So then we were able to find a PFT. You can see the FEV1's 52%. So spoke with Ms. Doe, follow up. She stated she feels the same as when we spoke to her in March. Her CAT scores have increased from 28 to 33. She is currently taking antibiotic steroids for a respiratory infection. We hear that so much. That is very common for us to hear. She struggles with a daily cough and lots of phlegm. She is unable to get out. So that right there, she's unable to get out. She's unable to get out of her home. She has declined so much, this is impacting her quality of life. That probably should have been bold. She states she prefers to take Mucinex instead of the flutter valve because the flutter valve does not seem to help. And so that's a very big statement. If it's not helping, then we need to up it. We need to go to something else. Oh yeah, that much. Okay. She has a frequent chest tightness, shortness of breath with activity, despite the use of 4 liters and her respiratory medications. Along with the shortness of breath, she complains of having no energy and is compliant with her CPAP and oxygen at night. Well, obviously they're not working. I mean, that's what we see here. She is very limited with her ADLs. She has general complaints of headaches in the AM and states she also gets migraines. So, of course, we asked for the NIV to improve symptoms and slow down the disease progression. Consider to evaluate for HFCWO and consider a mucolytic. So, I mean, does this sound like your typical patient you probably see very often? You know, this is painting a story for the physician that probably only sees this patient once every 6 months. And we talk to them every month. And we track these symptoms. And we can show them data. We can actually show them, here's where they were, and here's where they are now. Something needs to be done before the 3 months that they have to wait to get into your office. So I'm at 31 minutes. Well, I'm almost done. And we started a little late, though, on mine. All right, so we're good? All right, so here we go. This is the corniest one I got coming up. All right, you ready? You ready for this one? Okay, so here's the no smoking sign. And you know what? We'll just leave it. My husband was super not impressed with that one. So then I just said, any questions that anybody might have? All right. Thank y'all.